Okay, COPD. Can we make COPD better? Can we stop COPD? Yeah, we stop people smoking. This is still our bread and butter, and it's still a lot of what we do. This is the extreme end of COPD. You see these X-rays. I run a team looking after a couple of hundred people in the community with COPD, and we look at X-rays of our patients, and they have X-rays where there's no lungs. When you do look at their lungs, you'll see great big emphysematous bullae, and when we do CT scans these days, you'll see there's practically no lung tissue sometimes. COPD had this reputation of being about these kind of people, the kind of chronic bronchitic, blue bloaters, and the pink puffers, the skinny, underweight people. Also, and this is why it's really important to be here today, COPD was thought to be a disease, if you look at the studies, average age in a study of COPD is about 60, 65, 70% men. Do you know what? That's not the truth anymore. Because again, in our cohort locally, our average age is about 78 and 72% are ladies. And I think the ladies, I'm not showing any of these slides about the epidemiology with smoking, but ladies are smoking more, they are more susceptible to the effects of smokes, and they get COPD earlier. So it's a really important thing to remember. So what am I going to do for you today? I'm going to talk you through where we're going with COPD now. About exacerbations, yes, and what we can do about it. There's a bit of controversy at the moment about steroids, and I'll deal with some of that, and then a little bit else to finish. So we are trying now, we're learning from the cardiologists, which I'm sure the cardiologists would be delighted to tell us how to work things, but we're actually learning from the fact, trying to understand about risk and understand how to adjust risk, we can actually look at risk and say, actually, these are high-risk patients, these are low-risk patients. We need to intervene in these, we don't need to intervene in others. We're not very good at that in respiratory disease, but we're trying to work on that now. And our aims are very much to reduce symptoms as well as reduce the risk, and reduce the risk of progression, of exacerbations, and if we can, mortality. That's really difficult, though. Why? Because people are going to die of something, and they'll die of several comorbidities, as we're hearing now. Why is that? Because you don't die in your 50s and 60s of your cardiac disease now. You don't come in with your heart attacks anymore. You get your COPD in 65 to 70-year-olds, and then you get small vessel disease due to diabetes and progressive cardiac failure in your 80s and 90s, and that's what kind of gets us now, until you live with your COPD very much. Exacerbations are really important. They lead to a fast decline in lung function, they lead to poor quality of life, they lead to a higher mortality rate. Oh, I was kind of flicked on that, but I'll do that again this way. This is how we're going to do things now. This is a global guideline. And it's worth unpacking this just for a moment for you, because this is our assessment of risk. We're putting people now into 4 categories, A, B, C, and D. And we're classing these people according to their symptoms and their risk. Symptoms along the bottom, risk up the side. And risk would be according to lung function. And we know people, for example, with an FEV1 spirometry of less than 30% are very high risk of dying. We know people who've got an exacerbation history of more than 2 are, again, a markedly increased risk of dying. And then there are various ways of measuring symptom scores. And so you measure people according to this: low risk, less symptoms; low risk, more symptoms; higher risk, less symptoms; and high risk, more symptoms. And you tailor your therapy to match those people. Does it matter, these things? Yes, it certainly does. And we, again, in the respiratory world, are not very good at fighting our cause compared with cardiology. This is a lovely study from Spain from about 10 years ago, where a group took a bunch of people with COPD who'd had an exacerbation, and then they followed them. And depending upon in the year before how many exacerbations they'd had, none, 1 to 2 or more than 3 or more, they followed them and saw how quickly they died. And if you'd had 3 or more exacerbations in the year prior to study, at 5 years, you were dead. 80% of you were dead. If you didn't have an exacerbation, 80% of you were alive. So this kind of history, this detail, is really, really important. This is from John Hurst's work from a very large London cohort study of people with COPD, which looked at gold staging, which is based upon lung function. So lung function would have been more than 50%, less than 50 to 30%, and less than 30%, and looked at their exacerbation rates. Yes, we know the more severe people do exacerbate more. Hospitalizations, 33% in the study, 47% of exacerbations were people with frequent exacerbations. But actually, people with mild disease, what we considered mild disease, and that's changed, because would you consider any organ to have failed by 50% and call it mild? I don't think so now, so we can now call that moderate. over the 22% of those people are still frequently exacerbating. So we really need to do something about this. Here's some really fascinating data. Sammy Suissa is a chap from Canada who's about the best COPD statistician in the world. He gets it. He's not just a mathematician. He actually understands the disease. And he looked at a group of 73,000 people in Canada who'd been admitted to hospital with exacerbations and followed them and saw how long they lived for. So some lived for quite a long time. But the scary thing was the 50% survival rate was just over 4 years. So if you were admitted to hospital in Canada with exacerbations, and this is a huge population study of all comers, you got a 50% chance of being dead at 4 years. Now, we need to pay attention to this. But he then broke it down a little bit further, which was really interesting, to look to see actually what happens then. How long have you got until your next exacerbation? And can you see, if you have your first exacerbation, you've got a period of time of about 4.5 years until the next one. And then they start coming sooner and sooner and sooner and sooner. And this is your chance of dying. I think this brings into account a lot of cardiovascular death as well. This is all-cause mortality. And people die quite quickly as well. So the time from exacerbation, from the first exacerbation, is 5.4 years, and then they get quicker, 1.6, 0.9, 0.7, 0.5, 0.4, 0.3, until by your 10th exacerbation, they're happening every couple of months. And that's what we see, isn't it, in hospital? We see revolving door kind of patients towards the end. And more scarily, and I've shown this already, you're not going to be surprised, that after your index exacerbation number 1, this is your chance of dying, if you've had your 10th exacerbation, you've got a nearly 5 times chance of dying at time. We know that. Is this important? Yes, it is, because if we can stop these exacerbations, we should do something about it, and stop, and we can do it without drugs. But perhaps also importantly is to realise when you're talking to patients, if they've been in hospital 2 or 3 times, you need to give them the right information and be saying, this is really serious. Next time they may not survive. And I say that to patients all the time, that, relatives come to me and say, but grandma survived the first three admissions to hospital. Well, she was quite lucky, really, given some of this data. That doesn't always go down very well. It's always my fault. But there is definitely a window of opportunity. But after that first hospitalisation, after that attack, and I would certainly say in primary care as well, early disease, chronic bronchitis coming on, early exacerbations, actually to intervene to stop the subsequent declines. Very important. Can we do that? So this is an uplift. This is the uplift study. It was a 3-year study which looked at adding tiotropium, a long-acting muscarinic antagonist, to placebo, but placebo patients were receiving standard therapy. So they were receiving long-acting beta agonists and steroids. And over time, there was a 14% reduction in exacerbation rate. That's quite an important number to remember. It's not 30%, it's not 5%, it's 14%. And pretty much every other study done looking at this class of drugs has shown the same effect, the same size of effect. A more recent study looking at people using a new drug called aclidinium showed a small effect on exacerbations, but these people were not exacerbators. These were people actually who just had symptomatic COPD. Salmeterol, long-acting beta agonist, and tiotropium in this other study shows, again, a significant reduction in exacerbation rates. You've got to be careful with these studies because you've got to look at the people who are put into them. And if you put frequent exacerbators into the studies, you're going to get a much more positive result at the end of it. That's good news, though, because it means we need to pick those people. If you look at this other study that Visha Vedzika did, looking at exacerbation rates and comparing people who are on tiotropium versus serotypes, so that's a long-acting beta agonist steroid combination medication, there was no difference in exacerbation rates. These 2 drugs make up 75% of the world's prescriptions for COPD, and serotype is one of the biggest, probably the second biggest selling drug in the world. Okay. What about other things coming forward? We've got other combinations now. We've got long-acting beta agonists and long-acting muscarinic antagonists, so anticholinergics and beta agonists coming forward. We've got LABA ICSs, we've already mentioned Serotype, we've got Foster, we've got Symbicort. What about LAMA ICS? They're coming through, and there may well be soon a triple therapy, the kind of magic inhaler which does all 3. Is it any good? Well, we'll see. If we look at the data we have, and this is a very big study looking at exacerbation rates, powered to look at mortality actually, looked at people on placebo, salmeterol, fluticasone, and the combination, the serotype combination, there was clearly a cumulative effect of the medications together. Not very big on hospitalizations because hospitalization numbers were small, but certainly look at steroid-requiring exacerbations, it was a significant effect.
Can I just check the combination that doesn't include TO?
No, that's long-acting beta agonist and inhaled steroids. So this is the serotype combination. These two go into serotype together. That's a very important question. So there was an effect. If you looked at mortality, because this was what the study was designed to do, and it was very, very ambitious to do that, very scary to do that as well, actually it missed its endpoint by a smidge. That's because they had to do a pre-final analysis, which then would have biased the results, and the statisticians then wound the significance back a little bit. But for me, I think the combinations do a bit. Again, it's a 14% reduction. I think it's quite a nice number, and it shows quite clearly that actually the combination therapies bars do not cross over with placebo. But interestingly, this was one of the first studies which showed, if you look at the red bar here, this is steroid, that actually after 2 years, the mortality rate with steroid alone starts to go up. And this was a little bit worrying, and it's being looked into. I'll come back to that in just a second. We know that actually putting tiotropium plus the combination, this is a triple combination together, also has beneficial effects on exacerbations. Interestingly, there are only modest effects of these combinations on lung function. Beta agonist will give you about 125 mils. Adding in a long-acting muscarinic will give you about another 90 mils. Interestingly, patients will not notice the difference of that. So when you look at quality of life, they don't actually, and breathlessness, they don't actually notice much difference with these combination drugs. But as opposed to exacerbations, do they work? Yes, they do. Steroids alone, this is a very old study, this is the older study, Sherwood Burge from Birmingham did this, showed that steroids alone do actually reduce exacerbations a little. That's why we do use them with the high-risk people. However, this is not without controversy. These are the 4 big steroid studies that were done early 90s, in the late 80s, early 90s. Looked at mild people and moderate people. Isolde was the one I mentioned already. This is a big American study, Lung Health 2. Euroscop was a budesonide study. A lot of people studied for 3 years, and the Cochrane analysis of those showed no effect on lung function and no effect on mortality or lung function decline. So they don't do everything we'd like them to do. They're not absolutely perfect. So what about steroids and pneumonia? Well, therefore steroids have to be put into context, which I'm going to try and do for you now. There is clearly an increased risk of hospitalization from pneumonia with steroids. That's been shown with every steroid. It varies according to steroid and according to their potency. So fluticasone is one of the most potent steroids we have and actually has the biggest pneumonia risk. Budesonide slightly lower than fluticasone has a slightly lower risk. It is there. And so when you're treating your patients, you have to weigh these things up. Risk of exacerbation versus potential risk of pneumonia. The risk is very low. The absolute risk is very low. We aren't seeing queues of people with COPD with pneumonias, but it still have to be thoughtful about this and be careful with this. And this was the Torch study, the risk of pneumonia, looking very clearly at it, that actually any steroid-containing medication, whether it was the combination or whether it was steroid alone, certainly had more of a risk of pneumonia than the long-acting beta agonists alone. So it is real, it is there. Is it relevant? I think that has to be put into context for the patient. What else can we do for our patients? You're probably seeing now, particularly in primary care, respiratory physicians sending everybody out of hospital on azithromycin 3 times a week. So I wish I had shares, and I don't even know which company it is, but it shares in their company. This is because of this kind of study. This is really useful. We don't quite know yet who benefits, but it is absolutely clear that within 2 months, there is a separation of placebo versus azithromycin on exacerbation rates. Again, it's about a 20% reduction. So is it significant for some people? Yes, it is. I did a little clinic this morning before coming here, and I had a patient in clinic this morning who said to me, I quote, "This was life-changing for me. It gave me my life back." Okay, and I believe quite strongly we will identify a cohort of patients who will really benefit and those who don't. So I use it, and those people who say, that, wow, this is amazing, we carry on. Okay, it is relatively safe. Relatively, you get a little bit of hearing loss. perhaps over 4 or 5 years. We know there is a slight increase in resistance in some organisms, and there is a risk of liver dysfunction, so we recommend occasionally monitoring the liver. Unfortunately, I've not had any particular problems with it. And not just the rates go down, but actually the number of exacerbations drop quite significantly. And so it's wonderful if you can shift these high exacerbators into a lower exacerbator class. You are lowering their chance of dying. So this kind of medication can be important. I've probably had people on these treatments now for about 2 years consistently. Many of them come on and off summer versus winter. Evidence is accumulating that they are useful. So I'm putting a case forward with the evidence we have for maybe personalising medicine a bit. This is where we're going. Our payers, people want us to give medications, our patients want us to give medications that work for them. They don't want to take medications that don't work. We don't want to give them the side effects of stuff that doesn't work. So we need to be personalised. So this Flumelast is not a medication which we can use in England at the moment, particularly outside of clinical trials. It hasn't got a licence. But its studies hinted at one thing. If you look just at this one in the middle, this group of people here who've got chronic bronchitis and emphysema do very well with this drug. Again, you don't give it to people without emphysema. You don't give it to people necessarily are just coughing or symptomatic, but people with chronic bronchitis and emphysema did very well with this drug. We know that actually people with COPD who have eosinophilia do very much better with steroids than those that don't. It's been known about for over 15 years that people with COPD, which is reversible, have an eosinophilia. This is a nitric oxide measured as a marker of eosinophilia. This is a measure of sputum eosinophilia. So we know that people do that, and you can measure it in sputum, but more importantly, you can actually measure it in blood. This is a sputum study showing that people stay exactly the same whether eosinophilic or not. And if you manage their disease according to eosinophils, so these people who've got eosinophils get rid of steroids, these people who don't have eosinophils don't, their exacerbation rates drop. This is a COPD study. It's been done in asthma as well. You don't need to measure sputum eosinophils. It's not easy. Well, it's quite easy to do, but you can't do it very easily. Why not? Because you can measure full blood counts. They are exactly the same. So anyone with an eosinophil count greater than 0.3 may well do better with a steroid. It's very, very interesting how that data is going to pan out. You're going to be hearing more about crossovers. Now, asthma is a disease with eosinophils, mast cells. You can get new asthma in the elderly. The oldest patient I've ever diagnosed was 87 with new asthma. You have airways hyperresponsiveness. You may be atopic, and you respond to steroids. In COPD, traditionally, you have mucky sputum full of neutrophils. You don't have airways hyperresponsiveness in the airways. You have it actually in the peripheries more. And you don't respond to steroids. And then there's a crossover in the middle we're now calling ACOS, okay, which may well have some of these eosinophilics in there, who kind of do a little bit of both. Okay, it's a crossover syndrome. Okay, drugs, done. Let's concentrate on the important stuff. What really works? Pulmonary rehabilitation really works. And pulmonary rehabilitation has gone from being available for 20% of our population now to being available for 75%. Anyone MRC score more than 3 needs to have it. It is cost effective. For every patient who has pulmonary rehab, we will save £150. So it's free in that sense. We should be all doing it all the time. It doubles your walking distance and reduces exacerbations. And I think that's a lovely way to sell it to patients. It is not about Lycra. They can wear their ordinary clothes. Okay, they get a bit scared. I'm going to the rehab, going to the gym. No, you can just wear ordinary clothes. Oxygen, get it right. Use your oxygen teams. Oxygen, we are now really getting that absolutely right, and that's very exciting. Body mass index is important in COPD. If you're fat, you need to get skinny. If you're skinny, you need to get fat, because people who are skinny die more than those who are overweight. Body mass index about 18 is far too thin. Okay, that's really important. And we mustn't forget palliative care. As I've shown you, these people, 50% survival at 4 years. These people are dying of their disease, whether it's going to be an end-stage cardiac disease or respiratory disease. So getting palliative care teams involved early is very important. Having the difficult discussions about where you'd like to die. Would you like non-invasive ventilation if you came into hospital? Would you want to be resuscitated? All of that kind of stuff is absolutely vital. And I'm going to finish off by talking about how we give our medications. This is a really very interesting study from Jürgen Vespo, which showed quite clearly that actually not taking your medications is bad for you in COPD. That actually, perhaps bigger than any drug effect, getting people to take the drugs correctly is vital. So if you adhere by 80%, you get over half 50% reduction in mortality, relative risk reduction. What's really scary about this is that the drop-off in people in the poorly adhering criteria, they were dying. It's massively significant. We have lots of inhalers. Do you get confused by inhalers? Do we give people one of each type sometimes? Isn't that bonkers? Okay, so I hate MDIs with a vengeance. Okay, I think they wish they were all banned. I never give MDIs without using a spacer. Why? Because we can't use MDIs. Okay, always give it with a spacer, so they puff in and just breathe in gently. DPIs are variable. There's lots of them around there, from the two relatively new ones to some older ones which haven't come very far. They're getting cleverer. We've got capsules. We've got colours and lights. We've got sounds now. We've got counters on the side which tell you how many you've got to go. They're really important, but again, you've got to show people how to use them properly. With these medications, you breathe in slowly and gently. With these ones, you tell the person to breathe in fully and deeply. Okay, but you've got to keep on breathing. And then we've got the other ones, which is the Respimat soft mist inhaler, which is a new class, which again, you breathe quite slowly. There's a few others coming on the market, so be aware of the inhalers and try and stick to one class if you can, because then their technique will be the same. Poor technique is not good. You get lower than expected delivery, you get reduced benefits. You experience side effects and in the mouth and the tongue. And we've talked about the skin. I think that's very important too, because if these drugs go into the liver too much, you will get systemic absorption. You will get skin side effects, particularly in the elderly. So they must be able to use it. Check it. Very, very important. If you do those things, you can do remarkable stuff. This is a horse having its spirometry measured. Okay, I've been told that this is from the vet school in Bristol, that you get having a horse on a treadmill doing an exercise test and having spirometry measured is the most terrifying thing you can ever see in your life. Having a horse galloping next to you while you're standing there is really scary, but you can do remarkable stuff. My main sponsors are still Philip and Morris and BAT and everybody else. We still have to stop people smoking in this country. I think e-cigarettes are useful in some ways, but are potentially, there's a black hole coming out there which we can't predict what's going to happen with them, and I am concerned and nervous about them. Why? Because the tobacco companies are buying all these cigarette companies up. That's not a surprise, is it? So we need to do everything we can. In all the diseases we're talking about today, cigarettes are bad for you.